Going on, everyone? Alright. Next up we got is Chapter 6. This is going to be head, neck, and spinal trauma. Really cool one. So, um, there's a lot of shit we got to go through, but most of it I'm going to be skipping over just due to the sheer fact that a lot of it is going to be useless information, and it's going to be information we already know from our EMT basic. So, the scalp, strong flexible layers of skin with fascia and muscle tissues. So if we look here, we have our what I call as F-POTS. So we have our frontal, parietal, occipital, and our temporal. We have our sphenoid. We have our nasal cavity, lacrimal bone, like our tear ducts, ethmoid, maxillary, and zygomatic, which are going to be our cheekbones. We also have FEMS. See if I can draw here. FEMS is going to be for our sinuses. So we have our frontal, ethmoidal, so frontal sinuses, ethmoidal, maxillary, and our sphenoid. Those are going to be our sinuses. Our cranium, we have our cranium vault. That's just going to be the storage of the brain. We have for our meninges, we have DAP, so we have our duramater, arachnoid, and piamater. This is going to be the layering, so the meninges are going to help protect the spinal cord and the brain as well. Cerebrospinal fluid is going to be a colorless solution of water, proteins, and salt that surround the central nervous system, and it's going to be absorbing shock of acceleration, deceleration. CFS is pretty important. We can go ahead. There's the reticular activating system. This can be responsible for our sleep and wake cycle as well as our consciousness. It's going to be in the upper brainstem, pons, and midbrain. And then we also have our medulla oblongata, which is like right around here. This is going to be for vital stuff such as respirations, heart rates, and peripheral vascular resistance. The way I remember is medulla oblongata is oblongata live long vitals. So there you go. We have our cerebrum. It's going to be comprised of two hemispheres. It's going to be more important for our higher functions. So we have all this consciousness, thought, personality, speech, motor control. Now we have our frontal, parietal, occipital, and temporal. I'll go ahead and look over these. And we have our phalanx cerebri, which is going to be the innervation between the two hemispheres. Cerebellum, which is going to be our fine motor control. Brainstem, comprised of medulla, pons, midbrain. We have also our hypothalamus, which is going to be our heat regulation center, most importantly, but it does have some other functions. Our thalamus, which is going to be our center between the pons and cerebrum, and our pons, which is our sleep component of our reticular activating system. Medulla oblongata live long, respiratory and cardiac cycle, vasomotor centers. Brain receives 25% glucose, 20% O2, and 15% of cardiac output. We have our cervical villus. This is going to be the main form of distributing our O2-rich blood to the brain. So as you can see, right as we come out the ascending aorta arch, you're going to come off to the left common carotid and right common carotid. Cerebral perfusion pressure. This is going to be the pressure that's actually within the brain itself. So, to calculate this, you're going to need at least MAP and your ICP. If you subtract the ICP from the MAP, you're going to get your cerebral perfusion pressure. Excuse me. If there's doctrine, not really that important. We have our cranial nerves, super important. So we have our mnemonic. On occasion, our trusty truck acts funny, very good vehicle. Anyhow, you have your olfactory, optic, oculomotor, trochlear, trigeminal, abducens, and so on. A big one that you're going to need to remember is our ocular motor when we do have spinal trauma. You might have like a very small fixed pupil and then you'll have one that's super blown out. This is going to be due to compression on our ocular motor component of our cranial nerves. We have all this stuff. Go ahead and review this if need be. Just some important cranial nerves to know. The ear, I'm going to go ahead and skip over this. The eye, stuff like that. We should know all this anatomy by now. Yeah, there's just so much stuff to cover, but a lot of it we can gloss over. So we have our 7 cervical, 12 thoracic, and 5 lumbar. Easiest way, Josh actually showed me this, is in the morning you eat breakfast at 7, you eat your lunch at 12, and then at 5 o'clock you have dinner. So 7, 12, 5. Within the spinal column, depending on where you're at, they all will have inner vertebral discs. This is going to be a padding of fibril cartilage that helps just aid within shock absorption or any axial loading stress the body may overcome. Man, they really go so overboard with this stuff. Within our cervical, so if you go all the way to the top, our first little notch in our cervical is going to be called our atlas. This is just going to permit in nodding up and down. And then we have our C2, which is going to be our axis, which allows us to go left and right here. Yeah, so atlas, axis. Thoracic spine is pretty cool. It just holds the entire body upright, moves with respiration. We have our different spinal assessments here with just abnormal formities. We have scoliosis, kyphosis, and lordosis. So you can see kyphosis is going to be this upper high arch right here, and then our lordosis is going to be on our lumbar, that C shape, and then scoliosis is just going to be an abnormal curvature. Just so. Spinal cord is really important, so it's going to be a portion of our central nervous system. Man, there's so much that we're not going to be using for the test, I'm quite sure. Just know the terms ipsilateral is going to be the same side, contralateral is going to be the opposite side on where it happens. Spinal meninges, we have the DAP again, dura, arachnoid, pia mater. Spinal cord is going to end around L1 and L2. So pretty much if you do have a spinal puncture, if they're doing an epidural, they'll at least go below these so they don't actually nick the central nervous system. Sympathetic nervous system we already know, as well as the parasympathetic. Here's our blood supply. Yeah, I really apologize if I'm skipping over a lot of this. It's just really like stuff we already know, and it has no importance. I think the only one thing I'm looking for is, of course, intracranial hemorrhage, and maybe just loss of sympathetic tone. So we have our contusions. So when we do actually have, let's say, blood pooling in here, we're gonna have an increase in ICP. We'll have stuff like the foramen magnum herniating, or our brain coming through there, and then we'll see our posturing. And we'll see things of Cushing's triad. Yeah, so here we have our Cushing's triad. We're going to have an increase in blood pressure. We're going to have a decrease in heart rate due to loss of sympathetic tone. Right? Yes. And regular respirations. Actually, excuse me. Don't remember loss of sympathetic tone with this. Here's the Fora Magnum. So much stuff. Decorticate and Cerebit, pretty important. Decorticate, if you're coming towards your belly button or towards your mouth, the core, think O, mouth, and then Cerebit away. Two breathing patterns that we might see with a brainstem injury is Shane Stokes. So you can see they're progressively getting deeper and faster breathing, and then there's a period of apnea between them. So chilling, not big chilling, and back to chilling, and then apnea. And here's where the biats is just going to be in a regular pattern of rate and depth. Super high periods of apnea, and it'll begin up again, and there. So you can kind of see this one comes gradual, and then it begins to stop. Both indicate ICP. Some things that we can look for if we suspect that our brainstem is involved is a widened pulse pressure, decreased heart rate, central neurologic hypoventilation, increase in ICP, of course, sluggish pupils, non-reactivity. This could be our third cranial nerve. Our ocular motor is being compressed, and posturing. If you really care enough, this is just for my sake, you can take a 12 lead and you can actually see systemic changes of ICP with widespread T-wave inversions. Really cool. Feel free to pause this if you want. Just a little note section on that. It's just going to be a release of so many catecholamines. Pediatric head trauma is no bueno. Axial stress is going to be our compression injury. So if we lift a weight that is too great for the strength of the lumbar spine, we'll actually have fractures occur from this. So this is, I would say, pretty important. Know this chart. If we have a fracture within this area, this is what will happen. So here's our neurogenic shock. This can be an interruption in the communication pathway of the central nervous system. So we have our adrenal cortex here, which is responsible for releasing epi, norepi, and dopamine. There's just going to be loss of sympathetic tone, so that stuff is not going to be able to be thrown into the body's circulatory system. So we've gone over that plenty enough. I don't think, like, really that's like the only thing I could see that is important in this chapter. Of course, we have our basilar skull fracture. We're going to see signs of raccoon eyes and battle signs and CASF draining. Here's that halo sign. Just don't put anything in that airway. More of like an MPA. You might actually penetrate through that fracture. There is the Lefort, which is a classification for maxillary fractures. So you can kind of see it gets low, high, and then it's the complete fracture. It's just a grading system. We have our epistaxis. Most commonly comes from a network of vessels called the Kesselbach's plexus. These actually just start rupturing and you get that nosebleed. Yeah, you guys should be pretty well on determining herniation is happening. Something that we can get is mannitol for ICP. If you ever see that on a test and you don't have anything else, just go with mannitol. So that is chapter 6. I do apologize it's so short, but there's really not that much important with it. Okay, so chapter 7, we have our chest trauma. Let's see here. How many pages? 11. Alright, so we have 12 pairs of ribs. This will form our thoracic cage right here. So we have different areas within our sternum that are going to be pretty important to know, at least for FISDAP, because why not? So we have our suprasternal notch, we have our manubrium, we have the body of the sternum, and we have our xiphoid process, which is going to be the lower portion right here. And then this right here is going to be deemed as our angle of Lewis. So just some important things to note. Diaphragm is going to be our dome-shaped muscular sheet that is going to be helping in aiding respirations. So as you inhale, the thoracic cavity will drive downward, creating a negative pressure. And as it goes upward, it'll create positive pressure increase. And go ahead and push all that nice hair out. You have plenty of accessory muscles, so you have your shoulder musculature, you have your trapezius, you have your clavicle, scapula, stuff like, you know, sternocleidomastoids. These will all help in aiding you to breathe. You have your scalene muscles, you even have your abdomen, you have your rhomboids that are in your back. These are all help in helping you respirate. Little anatomy thing here is this little attachment piece. You can see you have your bronchus, pulmonary arteries, and your vein. This little area is going to be called your hilum, which is the attachment site of all these little tubes. Left lung will contain 2 lobes, right lung will contain 3. This is just going to be due to the fact that the heart will actually sit right in this little notch here, so the right lung will actually have allowed more space. So the heart will sit right there. You do have your pleural space. This will be bathed in a little bit of cerebrum or just some generalized fluid. You have your visceral and your parietal on top. This will help in reducing that friction. Or serous fluid, that's what it is. Mediastinum is just going to be the generalized cavity right here. It's going to house the great vessels. The heart, we should all know this. So the heart actually has a pericardial cavity, which also carries serous fluid. This is going to help anchor the heart, protect it from any trauma, and prevent overstretching. And it will go the endocardium, myocardium, and epicardium. So I'll just know those. Great vessels, I'm sure we all know. We have the esophagus, which will transport food and drink from the oral pharynx to the stomach. Blunt trauma. Penetrating, I'm sure we can skip over. So rib fractures are going to be pretty dangerous. Usually with a solo rib fracture, you should be okay. But when we see things like multiple fractures of the rib, this is where things can get kind of dangerous. So as you see, we have rib 2 through I think it's 6. These are actually all broken. You'll get something that's called paradoxical chest movement or a flail chest segment. So this will, as you see, as you inspire, that rib cage will go inward, and then as you expire, it'll be pushed out. So no bueno. Treatment for this is going to be wrapping this down tight and just having it back against the chest wall. Yeah, here's our flail chest. There you go. Reverse the pressures, restore tidal volume, and decrease the pain. We have a pneumo here, so we have our pulmonary injuries. So this is just going to be considered our closed pneumothorax. Assessment findings here are going to be no JVD, very important, and we're going to just have unequal chest rise and fall and unequal lung sounds. This can develop into a tension pneumo. So treatment for this is going to be that you're going to want to do a pleural decompression, second intercostal space above the third rib. Now we have our tension pneumo. Hold on. Okay, yeah, this is still simple pneumo. We have our open pneumothorax, so this is going to do, let's say, penetrating trauma. Air will actually be coming into here. What we'll be doing for this is doing an occlusive dressing. That is what they need. If we do have signs and symptoms of a tension performing or showing, just go ahead and burp the bag and then, or burp your occlusive dressing and then go ahead and close it back up again. We have our tension, signs and symptoms is decrease blood pressure, increase heart rate, JVD, and tracheal deviation is going to be contralateral. Needle compress. And our hemopneumothorax, we're going to see muffled lung sounds, tracheal deviation, and flat neck veins. If we have pulmonary contusion, just be ready if there's a couple fractured ribs, just to look for that. But these can get kind of dangerous. You can have things microhemorrhaging. This will irritate your tissues. They'll start the inflammation process. Fluid will shift from intravascular to interstitial, and you'll have pulmonary edema. And you might actually have evidence of pulmonary hypertension developing. Here's all your signs and symptoms. Hemoptysis is a pretty big finding. We have our blunt cardiac injury. Just be careful with the chance of pericardial tamponade from the pericardial sac. That if you smack the heart hard enough, you'll have that microhemorrhaging, and you'll have it fill up within the pericardial sac. No bueno, very bad. Here's going to be your EKG findings. And you'll be in Beck's triad, which will be our low blood pressure, distended neck veins, and our muffled heart tones. Commotio cordis should be good on that. We've gone over pericardial tamponade way oftentimes, so we should be good. Treatment on this is going to be a pericardial centesis. They come in and just inject the fluid out of there. Super simple. I think all of these, they're just going to be so rare that they're not going to be really gone over. Yeah. All stuff that should be pretty good. A lot of it, I mean, it's really basic stuff. It's just some of the anatomy, they kind of go a little bit overboard. They really kind of push that paramedic knowledge, but I mean, assessments basic, treatment basic, besides like pleural decompression. But let's see here. All right, we'll do this one real quick, and then I'll stop it for the next video. So we have our abdominal and pelvic trauma. I guess we can just start skipping through some of this. So our, what cavity are we in? So in our abdominal cavity, we have our peritoneal space, we have retroperitoneal, and then we have a pelvic space. So peritoneal is going to be organs within the peritoneum, of course, and then we have organs that are posterior within that peritoneal lining, and we have our pelvic space. Definitely memorize this little chart right here, just so if they tell you, patient has pain on the upper right quadrant on palpation, you have evidence of Murphy's sign. We can suggest that the liver, you know, something ain't doing too hot. Or cholecystitis. That's what it is. Our digestive tract, we should be all very familiar with how that runs. We have, you know, sinus comes over, comes down. We have a bunch of accessory organs. So we have our liver, which is going to be the largest organ in our body, or in our abdomen, excuse me. It's going to be responsible for detoxifying and producing bile, storing glycogen. We can actually cause this. If we gave glucagon 1 milligram, this will activate the release of glycogen, which is a stored form of glucose, and increase our blood glucose level. Really wish we carried it. It sucks that we don't. Yeah. We have our gallbladder. This will drop bile into the duodenum for fatty foods. Just aids in digestion with enzymes. Pancreas. We have our islets of Langerhausen or Langerhausen. We have our glucagon and insulin cells that will be released when need be. Spleen. It's going to be used in our immune function and stores a large blood volume. We have our urinary system with our kidneys, ureters, and urethra. Kidneys are going to be responsible in a giant portion of the renin-angiotensin-aldosterone system. So you can kind of see they throw the renin out, it converts into angiotensin 1. ACE is released from the lungs and converts that to 2, and then you will get your systemic vasoconstriction and aldosterone and all that retention. So kidneys kind of important. So just know that this system process happens. Genitalia we should be good on. We have our vasculature. I don't believe vasculature will be anywhere remotely close to our test. But if you wanna study this, go for it. We have our peritoneum. The mesentery is kind of cool. It will just really just suspend and hold that posterior abdominal wall and just kind of keep all these organs in place. Yeah. So we have our injuries. So right here that we see is evisceration. This could be protrusion of organs from a wound. Really high risk of infection. The only thing we're going to be doing is wet, sterile dressings just to do some infection control. That's about it. Yeah, I think yeah, this wasn't really a very much important chapter either. It's all very basic. Just understand with the organ that's affected, what kind of things you might see. We have our spleen, well protected by our lower ribs, back flank, can bleed profusely. Important assessment here is our spleen. It will present with associated pain. So we know our spleen is located in our upper left quadrant area. You'll have a referred pain in the left shoulder. Will be it'll be called Kerr's sign. Other than that, kidneys will be found as localized or flank pain. You'll have hematuria possibly if those are injured. Your liver will present with right shoulder pain as it's in your right upper quadrant. Peritonitis, pretty important one that I'm sure that will be going over. You'll present with rebound tenderness, and patient might be guarding, so those can be your assessment findings. The perineum can store a lot of blood. Anywhere in the abdominal cavity, a lot of blood can be found. So management of these people are going to be mainly supportive. If you're going to want to sustain a blood pressure at least above 80 systolic, give them fluids. And if the patient's pregnant, left lateral recumbent. So yeah, that is chapter 8. 2 more to go. Yeah. So